I learned about his disease through what I would call the family meeting. My mom says, I think your dad has Alzheimer's disease. This is a life-shifting discussion, and you go through the whole stages of grief, possibly all in that discussion. The question is, what do you do next?
Navigating Alzheimer's disease is just as complicated as the disease.
I really think that our physicians, our doctors, need to know more about Alzheimer's dementia.
Maybe some of them are still coming from the place where Alzheimer's isn't a disease that you can do much about, but there's a lot we can do to live with it. There's a lot we can do to live with it.
After that family meeting, I went back to training to be an internal medicine doctor, but I was constantly Googling, how do you stop Alzheimer's? How do you reverse Alzheimer's? What's the cure? I always wanted to do something that I felt connected to, and I decided, okay, I'm going to pivot to dementia and Alzheimer's disease.
Alzheimer's is the most common cause of dementia. Proteins are building up in the brain. The first one is amyloid protein, first as a small fragment and then forming plaques in between the nerve cells. Over time, that stimulates an abnormal environment in which another protein called tau protein also forms a clump inside the nerve cell. And when that happens, then the nerve cells gradually, over months to years, begin to break down. And when nerve cells break down or their connections break down, that's when we have the dementia, the cognitive impairment.
When it comes to medications, we don't have many. The medications we do have, they don't treat the disease that's causing it, they treat symptoms.
People have probably heard about the new treatments, aducanumab, donanemab, and lecanemab.
These new drugs can remove amyloid from your brain, and we think that's incredible.
These treatments are only approved for people with early Alzheimer's, but it looks like there is a mild slowing of memory loss and people stay in a milder state longer, but it's not a large effect. Medicare says they're going to cover it, so that's a big step forward. But a big problem is there are a lot of inequities in access to care.
These drugs are all going to be given through IV therapy, and this does not exist in small rural hospitals. It does not exist in doctors' offices. We already see disparities in Alzheimer's disease diagnosis and management, and this is just going to be amplified. The other thing is that these drugs were not tested in broad groups of racial populations. We don't know what the social determinants of health have in their role in Alzheimer's disease.
In the long run, I still think a drug is going to be helpful. We just need time to figure out what is best and what people are going to want and what it looks like.
Here, I think that's good.
That good?
Yeah.
Okay.
Right now, what people really need to know is that the day-to-day management of the disease is more important than the medication.
My mission is to let people know it's important to get diagnosed early.
People might be experiencing changes. They're not going to report it necessarily because of the stigma and the fear. To me, it makes sense to normalize normal aging, to explain to people as we get older, sometimes we're going to experience thinking changes. Most of the time, that's normal. Walking into a room, not knowing why, not paying attention or needing more focus in order to get things done. These are normal changes, but they also might not be normal. And so if you present it like that and then say, are you experiencing anything that looks like that? You've now opened the door so that someone might be able to tell you how they're really feeling. Or if a family member has observed a change, if someone says no, well then wonderful. I'm going to ask you next year too. You're reminding people you're thinking about their brain just like you're thinking about their heart and their blood pressure. If you end up hearing a response of, no, actually I am worried, well now you've opened the door for a proper evaluation to investigate this further. The most important thing for primary care to know, they don't need to diagnose Alzheimer's disease. You just want to understand what is the context. I want to know, what exactly are you experiencing? When did it start? What does it look like? More often than not, it is a family member who's raising the issue. I think that's the power of denial. It's also the power of the disease. It can actually affect your insight, so you're not noticing some of the changes happening to you. And so you want to also talk to someone who knows them well. So this is the family member. Are you noticing any changes? Perhaps you haven't been saying anything, but you actually have wanted to say something. What are you observing? Then you also want to rule out things that are pretty easy to rule out and could be treatable before we even get to the conversation of Alzheimer's disease or anything that's really scary that starts in the brain. We always have to know, what is a person's mood like? Screen for depression or even anxiety. Many times a medication is causing a symptom. Do a medication reconciliation or a very thorough med review. Disrupted sleep can affect a person's memory. Thyroid conditions, vitamin deficiencies, those can be found on a blood test. Then you also have to do a cognitive test. And so the cognitive screening tools that are commonly used are the SLUMs, the mini mental, and then the MoCA. The mini mental and the SLUMs are really good at detecting dementia, but not as good at detecting mild cognitive impairment. The MoCA is better at doing that, but it's a little bit more intensive and time-consuming. What I would want primary care providers to know is no one expects you to do this in one visit. In fact, it's better to do it over planned multiple visits to allow both the patient, family, and yourself to develop a plan of what you want to do.
As we did it, and as I failed, and I knew I was failing, that's the hard part. Like, people think you don't realize that you're failing, but you know you're failing at the time, and you're trying to be honest, but there's that part of you that just wants to cheat.
Because cognitive screening shouldn't be used to provide a diagnosis, you can interpret the results in a couple ways. One, you could tell a person, listen, you scored perfect. At least based on this screening, things look pretty good. This makes me think your symptoms, while real, could be due to something else and not the thing you're fearing. If the testing is low and they scored poorly, you can say, well, this shows that your symptoms are lining up with how your brain is performing on this test. And that makes me worried that something is happening. Why don't we investigate this further? The third is that a person denies what the test is showing, whether it's good or bad, and says, no, something is wrong or something is not wrong, and why are you bothering me? And then you just have to put it in context of, well, this was just meant to help me figure out what to do next.
After that, you can do a brain scan to see if there are signs of Alzheimer's or nerve cell loss or signs of something else, like hardening of the arteries or stroke or too much water in the brain, hydrocephalus. And then we can get more detailed cognitive testing. So those are the components that could either happen in primary care or specialty care or both. Ideally, we're going to build a better interface between primary and specialty care, and we'll really be working together on this.
As a specialist, I'm biased. So I would say every person should go to see someone who specializes in memory and thinking abilities. That being said, that's not feasible. That's not the real world. And so the standard answer to who should be referred is someone who's young, under the age of 65 or 60, someone who has atypical symptoms, and someone who has rapidly progressive symptoms.
Another huge issue is we don't have enough specialists to deal with the population that's aging and that requires that type of care.
I live in Cambridge, Boston. This is medical mecca. And it was literally months before I could even get an appointment with a neurologist. If this is a problem in the Boston area, I just hate to think about patients who live in areas where there are just far less medical resources.
Soon, I hope, the primary care doctor will be able to order a blood test. So if they suspect that it's Alzheimer's, they can confirm that. But they're not available yet. In parallel with the advances for the diagnosis and treatment of Alzheimer's, we need better care management. You know, there are a lot of really practical day-to-day concerns of the disease. And patients and families rely on primary care to help them figure out how best to manage it.
I can't control what's happening in my brain, but we can control my environment. And hopefully, as this progresses, it sets up a base for support down the line.